Thank you, Dr. Sanjay. Yes, I welcome Dr. Virendra to the course, and please be seated there. So, as Dr. Rajesh mentioned, that we need to use toric IOLs, and just one point I want to highlight here is that whenever we counsel our patient now, our counseling should always start once we have done keratometry of the patient. This is the one change in last 4-5 years we have done in our practice, because you counsel the patient, you just see patient has cataract, your counselor does all the counseling according to monofocal lens, and when you do keratometry and you find out that he has 4 diopter of SIL, so then the whole counseling changes. Again, you have to tell patient that, you have toricity, you have this, and you have to go for toric IOL. So again, that burden of counseling is there, and then patient also thinks that what's going on. So you should always do keratometry first before you go in for your counseling. And SIA, as Dr. Rajesh mentioned, is very important that you have your own SIA. So once you have everything in place, you know that what model of the lens you have to use, you know that what is the steep axis where you are going to implant the IOL. So then the next step is to mark the reference axis on the cornea. So this we do without dilating the pupil. So this also you have to tell your staff that, as soon as the patient comes for surgery, your staff has a tendency to dilate all the patients. But you have to tell them that the toric patients, I need them undilated first. So there are various methods to mark the reference axis. You can use the ASICO bubble marker, which is there. And there are electronic toric markers. And the technique which I like is to mark it on slit lamp. So you make the patient sit on the slit lamp with the head in the straight position so that there is no effect of cyclotorsion. And then you narrow down the slit beam, and here I'm using a 26 gauge needle, and with this sharp needle I'm scratching on the both side at the limbus. Now how does it help is that once you have these scratch marks, then you put the ink at the tip of the needle. So these marks are now very thin. Otherwise, if you make mark directly, so those marks are very broad. So these very thin marks are there on the cornea. And many times when you take the patient in the OR, if you have only the ink marks, they tend to fade away. So, but these scratch marks, they never go away. So now once you have this reference marking at the 0 and 180 degree, now the patient is taken for surgery. Now you can see the effect of the cyclotorsion here when the patient is supine. Here you can appreciate that the cornea is very dry. Intentionally it is, because now first we have to put the steep axis marking here. So don't flush the eye with the BSS. This is the Mendes degree gauge. It's always better if you use this titanium degree gauge instead of using the steel one, because steel, this instrument gives a lot of glare and it interferes in between. So again, I'm using a 26 gauge needle, which is very fine, and put ink mark over it. And this is the steep axis, which is around 95 degree in this case, 95 or 96 degrees. So you can see if its cornea is dry, it takes up mark very well. And this is the Boris meridian marker. On the underside of the blade is the ink mark there. So you align these two dots and wait for 5, 6, 7 seconds so that it takes up the ink well. And then you flush away the excess ink which is there. So now you have your steep axis where you're going to implant. You are going to align the toric IOL laser marks which are there. And these laser marks, they signify the power of, the least astigmatism. The capsular axis size has to be perfect in toric IOL or any multifocal IOL, as we all know, because that is what keeps the IOL in the perfect position at the perfect place. And you can use OVD if you like, but I don't prefer using OVD as it's very difficult to remove all the OVD, and if you have any OVD remaining behind the IOL optic, it may cause post-operative rotation. So this is the hydroimplantation technique. I just put the irrigation cannula in the anterior chamber. It maintains the capsular bag very well. And the leading haptic and optic goes. If you are using OVD, remember that you have to thoroughly remove OVD as much as possible. So here the Kuglen hook is used to dial the lens in the capsular bag. So once this lens is in capsular bag, you can bimanually rotate the nucleus and align it with the steep axis. Now see, you can very well appreciate that the rexis on this side is smaller, you know. There is a lot of overlapping here in this area, and I'm very particular about sizing. So now here I go and put OVD over the IOL optic, use micro scissors. I'll skip that. Okay. And I enlarge the rexis to the optimum size. So that's what finished this case. Remove all the OVD in front of the IOL optic and see the final alignment, and be careful when you are hydrating your wounds that your lens doesn't rotate. Most of these lenses which are having a hydrophobic acrylic platform, they are having a very good tacky nature, and they adhere well to the capsular bag, and you need to tap the IOL to the posterior capsule. Now you can see the IOL is very well aligned with the steep axis. So that finishes the case. There's the same case. Okay. So you see the sizing of the rexis has to be very good. So post-operatively, Dr. Sanjay will be covering the cases, how to determine whether the IOL is in perfect position or not. So I won't touch that part, but I'll just like to mention one thing here, that this is the retroillumination image on the optical biometer, Tommy. It has two lines here. One green line you can see, which is the reference axis, 0 to 180. And this yellow line is what we are aligning it with the toric IOL marks, so that you can come to know that where is your IOL sitting. And just few things I would like to add to what Dr. Rajesh said. This is one very nice study which I would like to share with you, which is very useful for everybody, that this study shows the influence of axial length and corneal power on astigmatic power of toric IOL which we are using. Normally, as we saw the nomogram, that if a toric IOL has 6 diopter toricity at IOL plane, all the companies use a fixed ratio of 1.46 to convert it at the corneal plane. So they say that 6 diopter IOL is giving us correction of 4 diopter at corneal plane. But in the extreme of the cases, as you can see in this table, that as the axial length increases, 29, 30 or 28 in high myopes, or if the corneal diopter increases, this ratio becomes 1.7 to 1.8. So it's not 1.4, it's 1.8. So let's take an example. If we need a 6 diopter at IOL plane, if we assume fixed ratio of the company, its correction is 4.1. But the real ratio in axial length of 30 and 48 diopter power is 1.8, which comes out to 3.2 only. So we are getting under correction. So in extreme of the cases, we can take help of this table, which is the study is there in JCRS. It's a very good study. And other thing which Dr. Rajesh mentioned, that we can also use these toric IOLs in keratoconus cases which are stable which are non-progressing, having cataract, and we can also use them in post-keratoplasty patients. So with this, I'll end my talk, and any questions from the house?